Well, good evening, everybody. Thank you very much for joining us tonight for this evening of Psychosis in Young Persons. I'm Sandy Vincent from the PHN Education team, and I'm joined tonight by our presenter, Dr. Gina Jose, who is a child and adolescent psychiatrist for child and adolescent mental health, perinatal infant mental health services, and whole of family services across the Central Coast and the Hunter New England region. We're also joined by Olivia Gregg, who is the clinical nurse consultant and GP liaison for child and adolescent mental health on the coast. Thank you very much for being with us tonight, both of you. Before we begin, I would like to acknowledge the traditional custodians of the land that we live and work on. For me, that is Darkinjung land, and pay my respects to elders past, present, and emerging. I do have a few things that I need to let you know about tonight. This session is being recorded, and the recording will be available on our PHN Education Library in a couple of days' time. As attendees, your cameras and microphones are automatically disabled, but if you do have questions during the presentation, please send those through to us via the questions box, which you will find in your control panel, and those will be answered at the end of the session. This session is an RACGP CPD approved activity for 1 hour of educational activity. An evaluation will come to you directly after the session. Please do complete that, as your feedback is very important to us, but it is also a requirement for the uploading to RACGP against that activity. It's now my pleasure to hand over to Olivia, who is going to start the presentation tonight.
Good evening, everyone, and thank you very much for attending this session. My name is Olivia. I am the clinical nurse consultant for child and adolescent mental health on the Central Coast in Gosford. The webinar tonight will be presented by Dr. Gina Jose, who I am very grateful to for doing the presentation tonight. Why we chose this particular topic to present on is the increase in the number of referrals we are getting from the local GPs on the Central Coast regarding young persons between age of 12 to 18 and also under 12 years of age that are presenting to the GP with the symptomatology of psychosis or psychotic features. I am very grateful to Dr. Jose for doing this presentation, and I really hope that it will answer all your questions, give you a brief idea about what psychosis in young children is and what to look for as a GP. Thank you, Gina. I hand over to you.
Thank you, Olivia. I'll just like to say that I am now presenting from the Wawakal land and would like to pay my respects to elders past, present, and emerging. And as Olivia has mentioned, we've talked, this is a topic that is quite broad, and I've kept the presentation, I think, in my view, to be simple and I guess as an overview of some thoughts and presentations, and largely inspired from the Australian guidelines for early psychosis, or first episode psychosis. And our views in presenting this topic has been also to explore what the differential diagnosis can look like, and so on. So please feel free to gather your thoughts towards the end, and we hope to have at least 20 minutes or so to have questions and answer them. I'll start presenting now.
That looks good. We can see your slides.
Thanks, Sandy.
Perfect. Thanks, Gina.
Thank you. So I'm trying to keep to our learning objectives, which is, again, as I mentioned, looking into a little bit of the differential diagnosis. There's an exhaustive list in literature, but I think I'll also aim to speak to the more common differential diagnosis and talk to how we can go about assessment and reassure the family and also other stakeholders involved in the young person's care. We're definitely identifying the early red flags of psychosis, and that is more psychosis in the context of a likely early onset psychosis or a primary psychotic illness. I've slightly tweaked the third objective in that I think it was meant to be identify the prodromal stages of psychosis, but I think that is a particularly difficult task, and so I hope to reword it, and I guess hope to look at it from an assessment and review of the different stages of psychosis. Of course, very important, and the biomedical investigations we'll have to go through, and the likely management strategies we could use in managing psychosis or psychotic symptoms. So it was, I was just sharing with Olivia and Sandy before we got into the formal presentation that it's really hard to get a real consensus on the statistics due to a number of reasons. Obviously, the studies in such an young population being difficult, and also because how it's difficult to categorize and define the phenomenology and the psychotic symptoms in early age groups. And this is perhaps going to be one of the main themes to my presentation all along. So what I have come up with is that in a clinical sample or a meta-analysis of over 19 population studies within a clinical sample is giving a prevalence of psychotic symptoms averaging of 17% in younger age population. So that is the pre-pubertal age group. And only about 7.5% in the adolescent age group, as a particular study indicates. I realize that this sort of, it refers to perhaps the adolescents underreporting, but I'm sure, Olivia could also speak to this, but in our clinical experience is definitely the case that at least about, I would say anecdotally, about 20% or more than 20% adolescents who present to us in the mental health services report of psychotic symptoms at some stage through their interaction with mental health services. So I guess it is hard to pin down an accurate representation of statistics, but it's just some guides. So say it's not an uncommon presentation at all. Again, so in a non-clinical sample, the median prevalence is referred to as 5%, an incident of 3% of psychotic symptoms in a general population. And I guess the other observation is that up to or anywhere between 75 to 90% of the psychotic experiences reported are transitory and they disappear with time. So it's talking to the not a pervasive or persistent pattern of having had the psychotic experiences through the period of their mental health difficulty or the young person's emotional challenges. So this is, I guess, one of the points we are trying to think through, which is that experiencing a psychotic symptoms does not always indicate a presence of a psychotic disorder. And I think as much as Australia has come to a largely mental health, aware, and there's a lot of mental health awareness and literacy that is being encouraged and advocated for within Australia as a country. But as a lay population, there's largely still the belief that a psychotic symptom is associated with a major mental illness like schizophrenia, and that comes along with the likely grief and stigma that the young person or their families and other loved ones tend to believe that this is a symptom of grave concern. I guess this reassurance or feedback is not necessarily very well known within a lay population, within the common man understanding of psychotic symptoms. So again, speaking to that, psychotic symptoms can also be seen as part of a spectrum or a continuum, and sometimes this can be experienced in a day-to-day perspective. And again, speaking to the first point there, that it can also be present in non-clinical populations who've not sought help so far at all, where it could be seen more as a sense of exaggerated self-awareness or self-consciousness, and it's not quite a psychotic symptom, but not the nature of it could be misconstrued as nearly reaching or seeming psychotic in nature. And again, these can seem like they sit in a spectrum where there is that hypervigilance that can coincide with a mental health difficulty, or whether that the person's nearly getting to be in a clinical sample, and then the other end of the spectrum where there is it's nearly bordering subclinical or nearly clinical threshold of psychosis or psychotic symptoms. So as I mentioned, the differential diagnosis, I think one of the most common differential diagnoses of when we see psychotic symptoms, one of the, I guess, more common diagnoses or conditions that we end up diagnosing is anxiety disorders. It's quite common in general in the young adolescent and prepubertal population. The psychotic symptoms are often seen in this group of young people in the form of visual hallucinations, and the level of there could be a level of paranoia that is, I guess, expressed as paranoia, but we generally don't use, and paranoia in itself doesn't necessarily mean paranoid delusion. There could be a sense of paranoia that comes in the context of social anxiety, where there is an extreme fear of judgment and the perceptions that people are talking about them, and they're watching them even when they are in social settings. And this can come to be really worrying for a lot of the family and loved ones and stakeholders that are involved in the young people's care, including school settings. These can be distinguished from a paranoid delusion, often in the context that they are transient. There can be very distressing moments associated with these experiences, but again, they are not pervasive, and they can be they can be challenged often when there's not that firm fixity around that experience. Psychotic symptoms can also be common in depressive disorders. I think later in a slide I talk about up to 40 to 50% of young people with depressive disorders could have mood congruent depressive mood congruent in the sense, keeping aligned with a particular low mood and psychotic symptoms in that context. Another common situation scenario we see these psychotic-like experiences is in the setting of complex PTSD, and I'm sure that maybe very commonly there is a lot of young people with early exposure to adverse childhood events that would need a lot of healthcare interactions, and I'd imagine they'd have a lot of interactions with primary healthcare providers in the context of both physical health, emotional health, and many other challenging moments. There's definitely need as to how much they end up getting to appointments, in keeping appointments, and actually getting in front of primary health providers. I'm not sure. My experience is that they struggle to do that. But in the population with complex PTSD, which is also the population who ends up I think later meeting threshold for borderline personality disorder, there's a common experience, or there's a common aspect of having these micropsychotic or pseudo hallucinations, as we refer to. So from a phenomenological perspective, we use it as slightly, we term them so to distinguish them from the psychotic symptoms, but how we differentiate it is often that they are more circumscribed, as in very limited to particular situations. So it's not very systematized, or they're not linked into another narrative, or so for instance, for example would be that they think their peers are against them, or there's a particular person who is angry to them, or who is after them, but that is not linked to the idea that it is because there is a bikie gang, or the police is involved, or there's a mafia gang. It's not as systematized and widespread and linking, interrelating, which is the systematized aspect is more in keeping with and supportive of psychotic symptoms aligning with the primary psychotic illness. Often in these differential diagnoses or other settings, the psychotic symptoms can be fleeting, and you can instill a sense of doubt or skepticism within that experience. It is common to see substance-induced or influenced psychotic symptoms. They can be again brief and surrounding the time that the substance use is intense or heavy. And later in subsequent reviews, they could subside when the offending agent is seized or there's no further access to substance use. Autism spectrum disorder. Now that, in fact, when we were thinking through the topics, there was, one of the topics that we thought about was trying to think through how much autism spectrum disorder in specific overlaps with the diagnosis of psychosis, or how much of an overlap there is, or how much of a situation we have where there's young people with high levels of function impairment with autism spectrum disorder that tends to be presenting as with psychotic symptoms. What I mean to say is it is a condition that has a higher risk. So autism spectrum disorder or most other neurodevelopmental disorders is having a higher risk of having a comorbid or psychotic syndrome, the psychotic diagnosis with the neurodevelopmental disorder. However, there's a lot of symptoms within the neurodevelopment disorders and how these young people express themselves that can be misconstrued as being psychotic symptoms as well. There is also concerns often raised around young people on stimulants having psychotic symptoms soon after initiation or dose titrations. I think, again, the worry or the incidence where it has been raised as a concern has probably been more than the times that I've seen it actually happen, that we would actually stop the agent because we were concerned around the nature of the psychotic symptom. So going into further aspects of differential diagnosis, so some of the ones that I mentioned in the earlier slides are clearly ones that is more in the realm of mental health, or the ones that we commonly see. And I guess I just wanted to highlight also that about 3% of the first episode psychosis or people with the psychotic symptoms can have an organic cause. And often in young people and also the older age population, I think we emphasize, as most of you would already know, the complete organic workup to rule out any organic cause. The common instances I have come across in my clinical experience of where there has been organic causes is when there's been temporal lobe epilepsy, SLE, and I guess increasingly now in the literature there is excuse me, talk about paraneoplastic syndromes, and specific NMDA encephalitis as some of the presentations where initial organic workup has missed the diagnosis. And there's increased, most psychiatric conferences now talk about NMDA encephalitis and flag the need for having screens and having organic investigations thoroughly completed before the diagnosis of a primary, before the condition of presentation is treated as a primary psychotic illness. So this is the more exhaustive list, and I think it obviously, in being in the primary healthcare provision space, it probably GPs and other primary healthcare providers would have more interactions with settings where young children who've come from kids hospitals, and where I guess it's less sometimes seen in a community setup or in a community child and adolescent psychiatry setup, and more commonly seen in the consultation liaison child psychiatry role for young people who would have care of these organic illnesses in Westmead Kids or like children, kids hospitals, and so on. So more perhaps having pediatric follow-up and then coming for further follow-up with GPs and their care providers. So as mentioned, autoimmune diseases as SLE, NMD encephalitis. And the reason why NMD encephalitis is so much come to the forefront is it's one of the presentations where psychiatric disturbance could be the leading complaints or the presenting problems. So that could be one of the first few changes noted before the organic illness is actually diagnosed. So the presentations could come into the mental health space or to GP as a primary mental health problem before having had any physical symptoms or other alarms or flags. Again, several chromosomal disorders, and I think many of my pediatric colleagues have often had, we share patients who've had these chromosomal disorders and then tend to develop psychotic symptoms in that context. Drugs of abuse, again, endocrine and electrolyte abnormalities can cause psychotic symptoms. In infections, in particular encephalitis, and obviously brain occupying lesions, medication-related psychotic symptoms, stimulants, again, as I mentioned before. I know this list talks about antidepressants. It's not something I've seen clinically, and antidepressants as in SSRIs. And then again, head trauma, epilepsy, I think these are very common aspects we probably thought of. So this could, we'll get to, when we get to the biomedical investigations, having the list of the differential is helpful because we can talk about how if we indicate an organic illness, then the biomedical investigations needs to be more exhaustive. Coming back to ASD and psychosis, as I mentioned, it's a common comorbidity. There is an increased risk of kids with ASD developing psychosis at a later stage. The misdiagnosis can come from their impairment in social function and the social interactions. It can come from the kids with ASD actually reading others' intentions as inappropriate, or what have they understood as to being the opposite person's intentions. They can come across as very concrete in their thinking and hence as also being irrational. They can also come across as being hard to challenge because they're so fixed in their thinking that could seem as though they have delusional intensity to their thoughts, their irrational thoughts. So it's quite understandable as to why it can happen. And it's something that we need to specifically keep assessing and reviewing and allowing to have for the person to be able to communicate their viewpoint around their views, especially if they have autism spectrum disorder. And sometimes their dysregulation can reach near the level of disorganization that can come about when they're dysregulated. It's harder to establish triggers, and the disorganization can meet the level, be thought of as a disorganization in movements that is in keeping with a psychotic illness as opposed to the dysregulation itself. Again, they have different constructs of understanding and their expression of language is different as well. And I think just reflecting, I think largely most of this information is easily available on the internet. And as I mentioned, there's the Australian clinical guidelines for assessment of psychosis and so on. But I think I was hoping to bring in our clinical observations into the presentation. And I think the other aspect we see with ASD and kids having psychotic symptoms as a way of presenting is also sometimes due to the lack of social connections they have. And that may not only be in the autism spectrum domain, it can also be for kids who struggle with social interactions because of attachment disorders and complex trauma, that sometimes the reactivity or the response of what psychotic symptoms complain or a report of a psychotic symptom brings about a lot of resources quite quickly, rightly so, because of the need for assessment. But sometimes the need for that reaction and response is seen as something reassuring, and sometimes there is a need for that connection that sort of maintains or that reporting, or that becomes almost a symptom for that response. I don't know if that is clear, but what I mean to say is it becomes a way of connection. the symptom reporting and the response receiving seems, continues as a form of connection for these young people who generally struggle from a social perspective. So what is early onset psychosis? And I think this term is very interesting in itself. What is early onset psychosis? And even as I was doing the presentation, I was trying to wonder, how do we actually define early onset psychosis? Because as such, it is a very broad term. It doesn't have a definition on its own. It's diagnostically a difficult phenomenology, which is what we're, I guess, talking about. That and explicitly distinguishing or identifying the phases is particularly difficult because of the fluidity of the symptoms. And I think the population in itself, and I think more broadly, in not only keeping into the topic of psychosis, in child and adolescent space, and developmentally, it's a very early phase. In particularly mental health diagnosis, it's not often in the child and adolescent space, we as psychiatrists think it's harder to categorize young kids who are only developing in their emotional sense, in their social sense, in their physical sense, to give them categorical diagnosis. So I'm sure it may be a common experience amongst all of you that child psychiatrists tend to stay away or maybe avoid diagnosis, which is categorical, but we tend to go towards the more dimensional formulation-based approach, and that is because of the fluidity of symptoms within these population, within the age population. Because of the developmental context, the social context, and emotional context, the diagnosis can actually change as well. Because at the end of the day, the diagnosis only becomes a cluster of it. It's only a group of symptoms put together, and if they meet threshold for that or not, it doesn't speak to the etiology, or it doesn't speak to the developmental context of what's going on for that young person at that point in time. And because things are forever changing in the younger cohort, having to stick to diagnosis can be difficult. So just speaking to an experience I've had working between the inpatient unit and the community team in the child and adolescent space. We were treating a young person, a 17-year-old young person, for psychosis, schizoaffective disorder, and quite a refractory state where we had tried several antipsychotics, and we were getting into even considering if we would need to think about ECT. This young person was in the ward at least 3 to 4 months, but before that, she was under the care of the community mental health team for up to a year and a half, where she was being treated for depression and anxiety. So what I mean to say is it's very common, and when we go into the red flags as well, we'll talk about this, that the diagnosis can change, and it is an evolving understanding of the young person in the context of what else is happening for them. And hence, the different staging of how we think of early onset, or more formally the term ultra high risk of psychosis. And this group of people often present with the non-specific symptoms first. And that is usually things like increased level of anxiety, sleep disturbance, and these brief intermittent psychotic symptoms that doesn't quite meet the threshold for psychosis. So I think to formalize things, perhaps the one-stop spot for what we can define as attenuated psychosis syndrome, or APS, is there as it's not a clinical diagnosis, but excuse me, I mean, it's not one among the clinical diagnosis in the DSM book, obviously, but it's in the conditions for future study. So how it is defined is that it is at least one of the following symptoms, which is that there is attenuated delusions or attenuated hallucinations, or a level of disorganization, most evidently seen in speech. Having any one of that, enough to get to a clinical attention, and this being present at least once a week for the last month, and the problems having been worse or the past year. Problems referring to the particular symptoms, obviously. And as with every other condition in the DSM, this is when the symptoms are not better explained by another mental disorder or other aspects like a depressive disorder, bipolar disorder, any of the mood disorder, psychotic disorder, and if the criteria is not met for another psychotic disorder, then you could classify them as having attenuated psychosis syndrome. I guess I just wanted to also say about when we say attenuated, it's easy enough for us to say that, but I wonder if there is, time is a crucial struggle, as I understand my GP colleagues would often have in the brief 10 to 15-minute consultations you have. But essentially what we do in the reviews we have with young people that we assess for psychosis is constantly exploring the level of conviction they have around the delusion often, and similarly the hallucination, the persistence of the hallucination, the level of distress associated with it. If it's, say, with the delusion again, can we challenge them? The level of skepticism is usually there, that it's not as firm and fixed as in the threshold or the nature of a full threshold psychotic symptom. Again, transition rates, most statistics I think has been hard to pin down, but I think of the one study that I could find, there is up to the transition rates of when the young people with ultra high risk transitions on to having a full threshold psychosis varies between 22 to 29%, again depending on at what durations they were reviewed for that, or as in 12 months or 6 months. The transition rates have varied slightly, but that's remained to be the transition rates. We've talked about that even in conditions like depressive disorders, there can be up to 50% of children who could have psychotic symptoms. Right. So identifying the early red flags of a psychotic symptom. What are the main things? I think this is, again, there is a big exhaustive list if we can find through literature. There's several ones. Again, I just wanted to bring through what I thought was most commonly seen from a clinical perspective. I think the most often the concerns we see in young people who we think is having psychotic symptoms that is likely to transition on is that they have a very significant blunted affect or an inappropriate affect. Their affect lability, as we call it, or that change in their affect within the appointments tend to be more grossly obvious than for other young people, say, who have who's not at high risk of having a psychotic illness. Say, for instance, all the differentials that we talked about, people with complex PTSD, anxiety disorders, they don't tend to have that effect, that influence on their affect so much as young people who are at ultra high risk and likely, in my view, who is likely to transition into having primary psychotic illness. There's likely mood swings, their marked decline in function. So that can be difficult for young people who have significant social adversities otherwise, and family conflict and so on, to have a clear, a timeline around when the marked decline has started. But in other populations where there's otherwise reasonable development with not much concerns, we can elicit a clearly marked decline in function over a few months or a period where there is obvious change in academic performance, or where there's been unexpected odd behaviors, like an unexpected out of character, sudden change of color, hair color, I mean, or sudden change in dressing styles, or rather rapidly changing preferences, which is not in keeping with a young person's personality prior to the time period that the concerns have started. There could be, so it could be that any of these symptoms or a few of these symptoms can all be seen as red flags of psychosis, or the young person being at ultra high risk of psychosis. Particular withdrawal from family without an obvious trigger, and that can be hard to elicit in itself, and an increased experience of feeling suspicious of others and distancing them from others. Now, keeping in context again, the neurodevelopmental disorders like autism spectrum disorder, intellectual disability, and other developmental difficulties, these the population of group who do have them, they are neurodevelopmental in the sense that's seen from an early age in their development, and that tends to be pervasively present. What we're talking about here is trying to elicit a timeline, and sometimes that can be really hard to elicit that timeline, but there is a distinct difference or some evidence to suggest that there is a decline over the past few months, 4 to 5 months, 6 months, a year. Depends on obviously when they seek out the supports. So just reflecting again from my experience working in adolescent patient units, which is where we see young people with psychotic symptoms or where they have transitioned to a full threshold psychosis, we ask for parents to bring in videos of when their child, or they thought that things were well for the young person. So sometimes parents have missed the prodromal phase or the early onset psychosis where people were, having these red flags. That's been missed by family members or other stakeholders like school teachers and so on. But in being able to see a contrast of how the young person was when they were well, like family videos and so on, to get a sense of how they were, is often a helpful indicator to know. Again, their appearance, their self-hygiene can be lost. There often is a sense of loss in the way they connect. So if we explore specific phenomenology, their thinking or the hallucination experiences, sometimes even if their delusions may have a systematized nature to it, meaning that very interlinking nature to it, they may struggle to express the associations with it. So that can get obvious as you really explore the stressful situations. They can tend to not be able to keep a line of thought or follow you in those conversations. Thought blocking, they could feel like that the thought is not, there is little they could express about their thought. And in fact, the whole content of the thought, there could be little conversations. They could be thinking very differently. They could have very altered perceptual experiences such as visions, hearing voices, and changes in personality overall. And some of the examples I mentioned above, that clothing, hair colors, and so on. And clearly unusual beliefs such as having a superpower and so on. Their general motivation levels and energy. And I guess most of all, whenever you have someone coming in and reporting these things, as we do with most other things, we get a family history of, especially family history of psychotic illness or any mental illness in the first degree relative. And that is again, in itself, one of the criteria that puts a young person as being at ultra high risk of psychosis. Now, this is the stress vulnerability hypothesis, and it's actually, I think it came first in the concept of psychosis particularly, but this is increasingly, we could say that this applies to other mental illnesses as well. And as this graph already indicates, there is a level of vulnerability that is there in the population, but it is also about, the level of stress. So as we know in the DSM, there was also, an acute stress reaction. There could be psychotic symptoms that comes in a context of an acute stress reaction. So that severe trauma and or severe stressful situations can bring about psychotic symptoms in people as well. So if you think about it, even less vulnerable people could have psychotic symptoms depending upon the intensity of the stress and intensity of the exposure that they have. And this is to speak to, obviously, someone who is having increased vulnerability would a smaller amount of stress would also push them into being at ultra high risk and then getting into a full threshold psychosis symptom. And I guess this is a helpful concept to have when we think of it from a management perspective, because often our approach in managing first episode psychosis or young people we know as being at ultra high risk is to decrease their stress levels. And as we will go through in the further slides, it is to address high expressed emotions within family settings. If there is family conflict, addressing things like social adversities. It's largely a general holistic approach to make sure that we're doing everything in our capacity to decrease the likelihood of transitioning from the ultra high risk period or phase to full threshold psychosis. So addressing things as family conflict, any comorbid illness, all that would would help to bring down the stress levels, which then keeps a person more well than likely transition to psychosis. So coming to one of the other objectives for today was to identify, or as I said, assessment and review of understanding the different phases of psychosis. As I've referred to several times already, in one of the previous editions or reviews of the Australian guidelines, previously they used to be referred to in stages, particularly, in phases. So there was the prodromal phase, and that's where the use of the word prodromal probably still remains. There's prodrome, acute phase, and there's the early recovery phase and a late or a problematic recovery phase. So initially it was thought of, psychosis was thought of in those phases. And I guess more recently, we've started redefining it in the context of stages, and I'll get to that in a minute. But if you look at it from a graph perspective and how things can go, largely before the person actually meets, the young person meets threshold for having had a first psychotic episode. That's when there is a full threshold psychotic episode. That's when the phase is seen as acute. Before that, they could still be identified as an at-risk mental state. That's this abbreviation ARMS. It's commonly referred to in sort of mental health reviews and so on, that we identify some young people as being as at-risk mental state. And within the at-risk mental state, so that could be really young children who would have a first-degree relative with a major mental illness like schizophrenia, where we are identifying them and already trying to work on their stressor levels and decreasing any chance of early intervene and decrease the chances of likely transition into further phases. And again, within the at-risk mental state, there is the ultra high risk mental state, and that's where that sits. And from here on, where we say the acute phase, that's where they have met threshold for the first psychotic episode. And they may or may not need inpatient stay. And then comes their trajectory of when they're seen as having a primary psychotic illness and further management for the same. So now, as I mentioned, the clinical staging model, largely with the idea that there should be intervention very early on, and obviously looking proactively into target populations who we could use, who could be recruited into for early interventions and supports. So there is stage 0, or who we would define as an at-risk mental state, someone who is at increased risk of psychosis, but there is no current symptoms. They would be seen as in the premorbid phase. So if you were to look at it from a phase, they're not yet in the prodromal phase. So that would be the first degree teenage relative of a person with the disorder. So if someone's already identified, you can start intervening in the concept of decreasing stress for the other young kids as well, or other teenage relatives of a first degree relative who has had a diagnosis of psychosis or schizophrenia. Again, so the interventions would be largely primary health level interventions, where we would be improving the mental health literacy, family education, support, reassurance, education around drug misuse, and cognitive, behavior therapy or cognitive therapy alongside challenging depressive and anxious cognitions or any of those cognitive distortions. Subsequently, again, stage 1A, that is when there is mild symptoms, including neurocognitive deficits, so where there could be executive deficits or intellectual functioning, the intellectual and IQ deficits, possible prodrome, and again, the indication of that primary health level where psychoeducation, CBT, active substance use. I think these are largely similar at this stage, and then come to being at ultra high risk of psychosis, where there is those moderate sub-threshold symptoms. So they're yet not meeting the threshold of what we would say is first episode psychosis. And if I guess from a service perspective, I was just thinking through, it might be helpful to have knowledge of in the primary health provider spaces that most of our early intervention psychosis teams, so for instance, on the Central Coast, we have the EP team, and in the Hunter, New England area, we have the STEPS. Both these teams work with young people from an early intervention model, which is different from the other public adult mental health services. And from the early intervention model, usually there is up to a 2-year intervention after the first episode of psychosis, where there is a holistic care and there is vocational support. And I think the idea is around secondary prevention aspects, not so much I think there is idea about focusing on the recovery and having an early recovery and a holistic aspect of vocational, emotional and other recovery aspects. So the young people would not meet threshold for the early intervention services like EP or STEPS at any of these levels. So these would be that young people who I guess would come in contact with mental health services who would get screened as saying they do not at the moment meet threshold for psychotic symptoms. We may identify them as being at ultra high risk or at clinical stage 0 because they do have a positive family history, but they may be not under the ongoing care of public mental health services. But I think that's where that understanding to be able to manage and keep reviewing and assessing these young people for any further concerning symptoms would be really helpful to be continued in that primary health provider space, within the GP follow-ups and within the contacts that they would have with all the other health providers. So this is clinical stage 2, and this is where we're starting to say that's the first episode of psychotic disorder, full threshold, and this is when again the referrals will be by primary care physicians, ED departments, and so on. But this is the treatment doesn't change very much in that regard. We still need all the other treatments we've been doing in the earlier stages, but obviously in this stage we would be looking at adding and making sure they have antipsychotics or psychotropics, second generation antipsychotic or antidepressant agents, mood stabilizers, and vocational rehabilitation is important for an aspect of recovery, no matter what stage of illness anyone is. And similarly, that's probably more specific to mental health services, and that's when the services as EP and STEPS would be involved. And that goes on, and that's most of them deals with the specialist care services and interventions would be around having to have specialist services involved and making sure the recovery is, an ongoing goal. So coming to biomedical investigations, I think, it's I just looked at the time. I might speed up a little bit. This self-explanatory. The main things to look out for would be basic blood work, fasting lipids and blood sugar. Prolactin is often, done, helpful to be done in the context of before any antipsychotics is started for with view to addressing psychotic symptoms, be it for anxiety at low doses or at high doses. Also for metabolic screening. MRI is recommended, though it's low yield as per studies. EEG again as led by any concerns around epileptiform activity or history of epilepsy, but it's routinely we ask for it more often than not. The underlying flags for if an organic cause is there, often it's atypical, flawed visual hallucinations in the sense it's fleeting again. If there's a level of disorientation or delirium that's quite fluctuating, it's very discrete episodes, the symptoms are happening and they're far apart, and a history of an already diagnosed organic illness. And I don't know how many, how many of you have had this experience, but hallucinations, particularly if it's persistently and only happening in the context of sleep, as in sleep, going to sleep and waking from sleep, they can be termed as hypnagogic or hypopompic hallucinations, and that can be quite within the normal range and nothing to worry. So some reassurance and feedback would be helpful. I'll just whiz through the assessment. I'm sure most of this is already what all of you are going through, which is doing mental state examinations as soon as possible, and detailed mental state examinations, including risk assessments. Look, I think one thing I'd like to appreciate is that, mostly in GP settings and other primary health settings, time is, a struggle, and I very much acknowledge that. In that, there's most of our assessments in the mental health space takes time, and there's just no substitute for that. There's just not. We just tend to spend, at least an hour and a half with young people and families, and review them as frequently as once a week, at least, to get a sense of where they are at. So that is something that we would need to, replicate in the primary health space as well, say if they're not receiving a specific mental health input. And again, non-judgmental, non-reactive, sort of youth-friendly language. Collateral information is very important, and serial MSE. So making sure that we have a serial check of the mental state examination of these psychotic symptoms, because they can change often, and it would be really helpful if we've had a few, assessment of the mental state examinations prior to then when they're coming into a mental health service. It helps to be able to understand it in the context of what other symptoms they've had previously. These are just some questions in particular about the nature of hallucinations and paranoia. Again, I think most of the paranoia I've already talked to, the degree of conviction, ask them to rate it in percentage. How convinced are you from 100% point of view that this is actually happening? From a hallucination perspective, it's helpful to ask where's the location. First and foremost, please make sure if we keep the questions open-ended and not as leading, because especially young people, they can be very suggestible and can follow on to our leads very promptly. So no matter how many times they've already given us that response, still the next time when we ask them, keeping it open-ended without suggestions is very important. Again, location, interpretation of the origin, what is their interpretation, and so on. I'll quickly jump on to the treatment approach. So CBT has a good evidence, and I guess very comparable evidence with this trial of antipsychotics, which is a treatment as usual in preventing transition or progression rates into full threshold psychosis. And omega-3 polyunsaturated fatty acid, starting that for young people who you suspect may be having a psychotic disorder. Look, it's very encouraged to have at least a period of period where they are psychotic or psychotropic free, and we can monitor their mental state before we start an antipsychotic. But if there's risk, if you're worried, if there's things, you can definitely start antipsychotics. Quetiapine, anywhere ranging from 25 to up to, with a target of getting up to 300 or 400 if you think it is a psychotic symptom. Aripiprazole, amisulpride, as you see, these options. Again, these are also available in the Australian clinical guidelines for psychosis, early psychosis or first episode psychosis. If this level of antipsychotics fail, olanzapine is an option, but we would really consider that very carefully. I'll skip over this because this is for the first episode psychosis with affective symptoms or mood symptoms, and that is, I think, particularly more complicated. I'm hoping, but it's largely similar with the antipsychotic trials being similar. Skip around the risk formulation. It's very similar. I guess what I'm wanting to highlight in the risk aspect is that, sorry, I was just pointing to it. Risk state. So risk status, the young person who is at ultra high risk may have a higher risk state to risk status for themselves, given the comparison to the other population. But within their own life, they may be at elevated risk to themselves, depending on what other dynamic factors or risk factors are going on for them. But again, that could be very much addressed by the available resources, and to make sure that we ask and assess for foreseeable changes in their life that could have an impact on risk. Those would be the main things. Last slide. I think, continue doing the great work, GPs are doing in such a strained and stressed times, which is, I think, family support. And that is something, I think is invaluable. We often don't get as much trust in, having in specific mental health services so much as the families and young people have in their GPs. And having that allies and having that space is very sacred for the families. Children are much more susceptible to EPSEs than adults, so like having those space to routinely and review for physical examination and EPSEs if they're on an antipsychotics, sexual side effects to be checked on as well, metabolic screening, please. That is something we often ask GP colleagues to help us with. Ongoing brief interventions around lifestyle choices, substance use, smoking, weight difficulties, and so on. I might stop there. I'll stop sharing my slides now and see if we may have some questions.
Thank you so much, Gina. That was wonderful. Thank you for sharing so many of your discussion points and examples around those objectives tonight. It was really great. Thank you for that. We do have a question. This is from Raymond. Let me just bring it over here. Raymond is asking, what services could we provide for a single mom newly migrated to Australia, no Medicare, and has a child or children who seem to be at the possible prodrome mild symptoms or even the UHR stage? And for further background, teachers at school have noted persistent learning and behavioural issues with the child currently in primary school.
All right. So teachers have noted persistent learning difficulties?
Learning and behavioural issues with the child.
Yes, okay. Look, I think the tricky question, perhaps a tricky part in that question is that they don't have Medicare. Sorry, I am not, unfortunately, I'm not very well aware of what that. I don't think there are, in fact, any specific services for that regard. But I think for someone who does not have Medicare but has who's newly migrated, depending on their migration status, there could be other. I'm not sure, if it's a student visa and so on. There may be different access points or how the financial side is covered. But look, I think if it's someone you've identified as an ultra high risk state, it would be a referral to a mental health service to consider depending on their risk and the impact on function. But if it's something that needs to be kept an eye on, and if there is not a high risk, if it's a function related concern, it would probably definitely refer to a pediatrician with view to exploring the learning difficulties, assessing, making sure they've had other allied health assessments. So IQ assessment has been done or not, their speech assessment has been done. You know, get the school to have specific school observations around their learning, peer interactions, their specific learning challenges, and what I guess their mental state concerns. So learning difficulties and behavioral challenges could be seen as from a neurodevelopmental perspective, including ADHD, autism, intellectual disability, and then, you know, reading, writing difficulties and so on. But if in addition there is specific concerns around psychotic symptoms or disorganization or so on, that they are keeping a serial monitoring of it as well in school setting. And I think early points of call would be a pediatrician, make sure the parents are getting, the parent mom is getting support, because again, addressing the family stressors, newly migrated single mom. The cultural supports could include, so there's cultural assessment team. I think I might even hand over to Olivia to give specifics around it. Again, it's a site-specific resource. So I know that in Western Sydney, I mean, in Hunter, New England, there's the STARTS program. In Western Sydney, there is transcultural mental health team and so on, who could also provide supports for mum as a migrant. And I'll stop there and ask Olivia if she has any other specific teams or resources she could think of.
Thanks, Gina. Look, there's certainly the services are out there in the community, and that's what I always tell the GPs. The services out there. If at any time you have any questions, just please give me a call on the mobile number for the GPs. I can certainly talk situations with you. I can look for services and definitely get back to you. But yeah, please do link and liaise with me, and I'll be more than happy to support you.
Okay, and I know, Olivia, your information is in Health Pathways, in the Central Coast Health Pathways program, so that all your contact details are in that program. And also the other option, I guess, is to go through the switch at the hospital and ask for the GP liaison officer. That be a way?
Not in the hospital, but through the CAMS number, which again is listed on Health Pathways.
Health Pathways. Okay, great. Thank you for that. Okay, and there's actually another question. Who is the GP liaison for the Hunter region?
That is a good question. I'm just trying to think through. There is not, as far as I'm aware, there is not a GP liaison officer. There's called what's the centralized CAMP centralized intake, which is again accessible only to the mental health line, unfortunately. So they're the team would be the first port of call for mental health services there.
And Simone, I would suggest as well that information will definitely be on the Hunter New England Health Pathways site. So that would be a good place to find that information as well. If in doubt, if you go through the PHN website, you can actually find the access to both the Central Coast and the Hunter New England Health Pathways sites. So yeah, good question. Thank you for that. All right, folks, we're at the end of our time. In fact, we're 3 minutes over and we don't have any more questions. Just to clarify for Stephen, yes, there was a question around the PDF slides. And yes, we will put the PDF of the slides with the recording, so you can have access to them through that. Thank you for that. So no more questions. Thank you so much, everyone, for joining us tonight. And thank you very much, Gina and Olivia, for joining us and for such a wonderful presentation. It was really awesome. Very grateful. And it's our pleasure. And have a really good evening tonight, everybody. And I will say good night and end this for all of you. Thank you so much. And please don't forget to do your evaluations. All right. Good night, everybody.
Thank you.